And do you know the age of the donor?
64.
64.
54. 64.
Yes.
And you're using a modified IOL injector to insert the graft?
Yes. Exactly.
Os cartuchos C.
Use the Monarch
D, né?
D. Yeah. D.
I have to deliver slowly. Close the side part. Like to check the orientation of the neck graft. Little taps in the center.
So he was enlarging the anterior chamber so he could check the correct position of the graft. That's why he's putting some DSS to enlarge the anterior chamber and check the graft orientation. Did you do any marks in the graft?
No.
No, in my routine, no. But this fellow uses F.
F.
Little origami. And I move to nasal.
Can you see the size? I think everyone can see the correct size.
Is it already in correct side? So how can you say it's in the correct orientation right now?
I use the Missouri.
After you do the mid-theory, but now you can see the size in the corner.
Oh, okay.
Here.
So they say they could see the graft is curling upside. So that's a sign it's in correct orientation. And they said they're going to perform a Mutsuri sign to double check the orientation of the graft.
Outra
So now he's centering the graft with indirect techniques.
Yeah. I press slow and remove fast.
So he's saying when you want to move the graft, you press slowly to the side you want to move and let it go fast.
It's more like releasing.
Releasing fast, yeah.
Rather than tapping.
The other thing I find helpful is I usually put a suture through the main wound, and that gives me one more area. I can use then my main wound to manipulate the anterior chamber.
Yeah.
Some cases you can do without suture. It's more dangerous, but you can do very slowly, gently.
No.
I like this releasing technique, but I assume that you need a little bit of anterior chamber depth to do this maneuver, because if you have a flat anterior chamber, I don't know if it's going to work, but I'm going to try next week because I really like it. So.
Yeah, with this maneuver you need some space to work.
Yeah. Then when you're happy, you reduce the chamber, yeah. Yeah, beautiful. almost done, hopefully.
Perfect. Perfect, Lisa. Una manca só. Isso.
Check. So,
Seems to be still a little bit deep, the anterior chamber.
yeah.
This is why it's moving the graft. Now. So sometimes if I'm happy with the centration, I put in a small bubble of air underneath and then completing the opening with the bubble of air.
The follow here. Yeah. Okay.
The anterior chamber looks pretty deep in this case. Are you trying
Yeah.
to keep as
Yeah.
shallow as possible to unfold it?
Put a little bubble this side, the center,
Great.
and bubble bump.
Yeah, as he's having some difficulty to unfold completely the graft, he's going to put a small bubble and perform a bubble bumping to unfold the rest of the graft.
I feel. Okay.
Ah,
There. Okay.
So he put in a small bubble inside the anterior chamber, and now he enlarged the anterior chamber with BSS so he can tap in the folded part of the graft. That's called the bubble bumping, so he can unfold the rest of the graft inferiorly. Yeah, now it's unfolded. And now enlarging the bubble
Yeah, you know, big anterior chamber.
Great, Rafael. Not an easy case to unfold the graft, but you did it.
Yeah, yeah. Okay, any questions? Thank you all. Thank you so much for, it's a very honor to be here today. And I'm very happy.
Great, thank you so much, Rafael.
Thank you.
Everyone
You can go
wants to
on.
ask something?
We switch to the
John,
slides.
para italiano.
Great, thank you so much.
Buon pomeriggio. Buon pomeriggio a tutti.
Grazie.
Great, thank you.
Great, thanks very much. So as part of the program, we'd like to have a presentation of some unknown cases, and please have the audience kind of interact with us as we walk through these cases. So the first case was a patient presented to me, a 61-year-old female, referred for an evaluation of a pterygium and cataract in both eyes. You can see neovascularization of peripheral cornea and subepithelial fibrosis. What is interesting is the extensive amount of astigmatism, 5.1 diopters in the right eye and 2.6 diopters in the left eye. But you can see it doesn't look classically like a pterygium. So thoughts on what this might be? Any thoughts from the audience? Marco. Are you ready, Marco? Are you ready? That's a pretty good throw.
Good catch.
Can this be like a diffuse lamellar keratoconjunctival proliferation rather than fibrovascular tissue seen in pterygium? So it's a form which is not typically like a pterygium.
Correct? Yep.
And it can involve all the quadrants of the eye rather
Right.
than the typical
Right. Yep.
nasal.
Right. And, you know, we'll walk through why it's different from a pterygium. These are also called solid nodular degeneration, but as you can see, it's quite different from a Salzman's case, right? There's a lot more NV, there's not a lot of elevation. And then sometimes these patients, depending on how extensive it is, are referred in because there's no history and they just see that it doesn't look like there's good epithelium and it's limbal stem cell deficiency. So why is it not a pterygium? Anybody on the panel? I mean, what looks different than a pterygium?
Well, there's no elastotic degeneration of
Right,
this conjunctiva.
right. It lacks that large conjunctiva tenons involvement that is the primary disease that moves into the cornea. So we know it's not a pterygium. Did you have a comment? Okay. And then what's different about, you know, if you look on the right here, the classic Salzman's nodule, elevation, and you can see in the top picture, we do get Salzman's nodules with neovascularization, but the neovascularization pattern here is quite different.
And there's a space, which you usually see with Salzman's. Do you have an OCT for us too?
I don't. I know you like OCT. I should have an OCT,
sad.
but I felt like I could make a diagnosis without OCT. But that's a very good point. I think it's a useful diagnostic step. Anybody want to comment? Anybody think this is a Salzman's nodule? Nobody really. Dr. Terry, your thoughts? You got to get the wall. You got to get the box.
I love this technique of passing the microphone. The first time I've seen it, only at S.I.C.S.S.O. Okay, so yeah, this doesn't look anything like a Salzman's nodule. There's not the elevation. All you see is the basement membrane advancement at the head of the vascularization. It looks almost like a quadrantial limbal stem cell deficiency in that area. You know, you've asked questions about whether or not there's any toxicity that this patient's had. Is there any contact lens wear this patient's had? Is there any previous surgery this patient's had? You know, the list goes on, but it's nothing like a Salzman. You could make a case for a very flat pterygium, but like you said, there's not the thickness of the degenerative elastoid degeneration.
Right.
I'm going to pass this again.
Please throw it around.
Here we go.
Well, first idea, without knowing the history, you would think this is operated pterygium that has recidivated in a flat way.
So, that's actually a good point, because we do see, if the patient said they had a previous pterygium excision, we sometimes see neovascularization scarring post-pterygium. So great, but no past ocular history, quiet, sudden, gradual loss of vision.
So the second guess would be a kind of atypical terriens, which stays on the
Atypical
side.
terriens, which OCT would help, but there was no stromal thinning. So a good point, because in pterygiums you have to see that peripheral thinning, and typically with pterygiums on that leading edge of neovascularization, we get the classic lipid deposition that really is the hallmark of pterygium. So the other one that we sometimes get in a case like this, especially if it's almost 360, is this limbal deficiency. But as Dr. Terry told us, no history of any exposure to any toxicity of drops or chemical exposure, no long-term contact lens wear, no chronic glaucoma drops. And, one thing that I don't show here, but the classic late staining of the epithelium. And if you want to have the hallmark of limbal deficiency, that epithelium takes up fluorescein in a late staining pattern, and it didn't do that. In the cases on the right, actually the superior case is a case of chronic severe dry eye, an MGD with secondary limbal deficiency. The middle case and the bottom case are chemical injury patients. So we kind of have a history to kind of lead us towards that. So this was not limbal stem cell deficiency. So what it is, and we were making notes in the chart and calling it atypical Salzmann's because they were more corneal than conj. And really, one of my fellows went and found these articles that actually have this name, peripheral hypertrophic subepithelial corneal degeneration, which I think is an absolute terrible name for this condition. But there are 4 reports in the literature all using this terminology, and so we kind of acquiesced and used PHSCD of these. So you can blame Mouse and Raber for the first description of this way back in 2003 with 6 patients. And again, they differentiated these patients because they had a lot more neovascularization than we see in Salzmann's, and they didn't have the conjunctival tenons involvement we see in pterygium. And then Gore came along and described 22 more patients with the same findings using the term PHSCD. Jared Tosta had 14 patients, and then Chargas 9 patients. So the differential, and the reason why it's important for clinicians to know this, is that all reports talk about a higher recurrence rate. And so, in fact, in this report, they distinguish this from other things. The common findings in PHSCD are flat subepithelial fibrosis, not elevated like Salzmann's. Extensive corneal neovascularization, very superficial, high astigmatism, and the patients are much more symptomatic than you get with a pterygium or Salzmann. They have a ocular surface, burning, stinging, kind of severe dry kind of thing. So they're very, very symptomatic when they come in. It's typically bilateral, usually supranasal is the most common, and it's more common in women. So I had the fellows go back and say, I want you to look up all the cases of Salzmann's ocular degeneration, and any case that we wrote atypical pterygium or atypical Salzmann's, and let's compare them. And so in this case series, we had 61 eyes with classic Salzmann's and 26 eyes that fit the description of the 4 previous case reports. And we had long follow-up because these patients kept coming back because of recurrences. So in our nodular Salzmann's nodular patients, we had 6 years, and PHSCD almost 6 years as well. And so the age, sex, race, laterality is pretty similar, but the PHSCD patients were much more symptomatic and a higher degree of astigmatism. And we reported our findings in the ocular surface. The other findings we had was, a Caucasian female is the most common, but the higher recurrence rate, and this is what I want to point out, if you diagnose these patients as Salzmann and simply do a superficial keratectomy, and our recurrence rate was very high. We had 84% of our patients who were primarily treated with Super K had recurrence. And so that is why we need to understand that this condition is different. So we started approaching these patients with more aggressive therapy, adding topical mitomycin and an amniotic membrane to the superficial keratectomy, and we certainly reduced our recurrence rate. So this case kind of points out, again, referred to me with severe limbal stem cell deficiency, but no past history of any exposure to anything, no contact lens wear. And again, this is a more extensive case of PHSCD. You sometimes can see them 360 degrees. This patient had 4 fingers vision, and again, referred for an ocular surface stem cell transplant. We just did a super K, mitomycin, AMT, and you can see the limbal stem cells are viable. There's just this degenerative change in the peripheral cornea that obscures the functioning limbal stem cells. And so, I'm not a fan of the name, but I think it's that we've added the 5th paper with this name. So, but I think, I've never had a patient send in with disease with the right diagnosis. They're all pretty much diagnosed as pterygium or Salzmann's. And it's important to know, because if you simply manage them like Salzmann's, you're going to almost have a 100% recurrence rate. And so adding adjunct therapy with mitomycin and AMT has really brought our recurrence rate down significantly. Mark?
I think that we've seen this also in conjunction with a pterygium, a true pterygium. Because have you ever had the cases where you had a true nasal pterygium, it looks like pterygium, smells like pterygium, has an OCT like a pterygium. But then there's another quadrant on the other side, on the temporal side, which looks exactly like this. And so when you review the literature, did you see any cases that were described where it was associated with a pterygium? In other words, another quadrant was associated, because what I've seen in just a few cases is something like this on the other side, and I've done a pre-conjunctival graft for the pterygium and then an amniotic membrane for that other area to prevent recurring. So, and when we send it for pathology, they call it a pterygium on one tissue on the one side, but don't call it the other, same vascularization.
And there can be somewhat of a continuum, and if you did a pre-conj graft in this case, it would probably be better than just doing a superficial keratectomy. I think the point is that, to me, it's more, in these classic PHSCD cases, it's more of a corneal degeneration. You really don't have to put the patient through a pre-conj graft in the classic case like these. And adding mitomycin and the AMT, which is faster and easier for the patient, they do well.
And the other thing on these is that there's a significant flattening effect and irregular astigmatism that I feel is even more so than we see with a traditional pterygium, because of that subepithelial elevation that exists. And so they have a lot, even if it's not very central, they get significant irregular astigmatism associated with these.
Correct, yeah. Any questions or comments? All right, very good. So we're going to our second mystery case with Dr. Karp.
If I could have my first slide, please. So I wear 2 hats, my cornea hat and my ocular surface oncology hat. And I got a call about this next case from one of my senior colleagues who told me, sorry to send this to you, but I have a nasty case of an infectious sclerokeratitis on a Friday afternoon, and the pressure is out of control. So this is a mystery case, which is also, I say, keeping me humble. Here are my financial disclosures, and I have an amazing team which helps me do everything I do. I thank Noah Cohen and my great fellows, Wee Sam and Wendy Lee, for their help, and my great panel and the Sir Nicholas family. So this patient was 66 and had a renal transplant, was on systemic immunosuppression, and had a history of a pterygium surgery. So we frequently see patients who had pterygium surgery. They've had mitomycin on bare sclera. Common in South America is radiation, or was radiation therapy, and so they come in with nasty sclerokeratitis, corneal scleral melts. But no pathology had ever been sent. He was just told that it was fine. And to his knowledge, he hadn't had any other things, but he didn't know. But then he had a regrowth of his pterygium, and his vision got worse, to almost complete loss of vision. He was on topical medications for steroid and his pressure. So hand motion vision, APD, pressure near 40, and what we see here is conjunctival injection. There's cells inside the eye. There's this corneal infiltrate, kind of feathery, this lesion and iris nodule. So I want to see who has the ball and who can give me a guess of what this sclerokeratitis and uveitis might be. Here's the iris nodule as well. So let's take some votes. Okay. First, who thinks this might be an infectious sclerotitis, keratitis, that white feathery thing, and uveitis? Raise your hand. Okay. So that's what my senior colleague told me. Who thinks this may be inflammatory type of disease, whether it's autoimmune or something else, some kind of, okay. Same hands are going up, but, okay. Yeah, I see, that's okay. Mark, you can vote as many times as you want. And, because you know it's me, who thinks it might? Okay, Mark Terry voted 3 times for all of them, just so you know. Oh, and some others, okay. Okay. All right, so...
Maybe we could talk about why people think they're 1, 2, or 3. Who wants the box? Who voted for number 1? Maybe we go back to that picture. Can we go backwards?
Yeah.
Well, Mark, you voted for number 1.
Yeah, because I didn't have the data. So, I mean, it's got hallmarks of infectious keratitis. You've got that feathery lesion there. You've got all this inflammation. The iris nodule throws you off a little bit, but, you know, certainly it could be infectious keratitis. On the other hand, it could also be all the other things you listed. I mean, you've got to start doing your studies and doing your scans, and not once to have this.
You want to comment?
So,
comment right there.
So what I wanted to say here is Victor Curtin was one of our founding 5 at Bascom Palmer, and he would say humility is only one patient away. So I really thought this was an infectious keratitis, and that's what my colleague told me, that's what it looked like. And so sometimes your mind is on one track. But this is what happened with this patient. So we did scrapings looking for infectious etiologies, which were all negative. I'll show you some other studies here. The B scan showed this thickened lesion, but there was no scleritis. The sclera was there. And my high-res OCT, which you know I love, showed me that there was thickened hyperreflective epithelium. And in some areas, I could see the epithelium going under. So on that lower one, there's like a finger of epithelium. So the cultures were all negative, which I was a little surprised. The OCT suggested that this was neoplastic epithelial process. And so I planned map biopsies and an AC tap. And so that was done in the OR, and Sandra DeBovi, my pathologist, called me and said, this is cancer. Now, I'm the cancer lady, but I was thinking that this was a mycetoma, something like that, because we get weird things in Miami, and I've seen several mycetoma or fungus balls. Guy had pterygium surgery, probably radiation. But this was not. This was cancer. So what happened here? I'm not sure. maybe that pterygium that he had taken off really was neoplasia back then, because it was just thrown away and we don't know, incompletely excised, and then he was on immunosuppression and the thing blossomed. So we do always need to think about ocular surface squamous neoplasia when any pterygium is taken off, whether you are doing it yourself or whether they have a history of it. And if we had known that there was neoplasia in there, then we'll talk about maybe we could have done some things to prevent this outcome. So always send your tissue for analysis. We know that between 1 and 15% of pterygia can have some neoplasia. It's the same risk factors, sun exposure, and if there is OSSN in there, then they have a higher chance of recurrence. They're not treated as if they're cancer. We just cut them off and do an autograft or whatever you do, instead of cryoing and analysis. So the OCT can be helpful, but again, pathology. So here is a paper showing 15%, and we did the same thing with Bascom Palmer, and I have to admit, I stole this idea from an ARVO poster. I go to ARVO and I look at everyone's posters and I think that's a good idea. And so we reviewed all of our pterygia to see how many pterygia were actually a surprise OSSN. So that's one of my messages here. So let's vote again. What would you do if your pterygia came back as an OSSN? So let's show of hands again. How many people, if you took off your pterygium and you did send it like we're recommending, and it said, oh, guess what, doctora, there is neoplasia in there, then who would treat that patient with topical mitomycin or 5-FU or interferon, whatever we would have, after the pterygium surgery? So how many people would do that?
It kind of depends on how extensive we felt our excision was, but low threshold for yes, treating topical as well.
So that's an important part, question that we'll answer, okay? Or further surgery, go back and do cryotherapy is an option. Both. Plaque brachytherapy, so this is what Dr. Farid, I'm going to comment on, or more careful follow-up. So for me, it depends on where is the tumor. So if you sent it and you talk to the pathologist and they say it's only intraepithelial at some margins, then treat them with topical of your choice. If it was deep and that was invasive squamous cell and not a pterygium, they're going to need, and I think a plaque is the best, or you'd go back and do more surgery and hope you get it, the deep margin. So then at least you know what you're dealing with. So in this patient who had, we know, squamous cell carcinoma, and uncontrolled pressure, pain, hand motion vision, something weird inflammatory going on the eye, we talked to him and he was in intractable pain on maximal medical therapy, and he didn't want to try to take it off and hope for the best with the vision, etc. He just said, I'm done. So Dr. Alabiad removed the eye, and this isn't a pretty picture. My son here said that's kind of not a nice picture to show after lunch. But what we found out here is that there was squamous cell carcinoma in the angle, in the cornea, and what's strange is he did not have intraocular surgery. It was only pterygium surgery, but it was in his cornea, and it was in the ciliary body, and it was very dramatic, and it was mucoepidermoid with differentiation. And the strange thing was is that it was in the eye. We know that if you do cataract surgery or any kind of intraocular surgery, you're opening the door for the cancer to go in, but he did not have that. So we know this is a nasty variation. Who has had mucoepidermoid patient? Anybody? So it's not common. It's very aggressive. I like to think that I'm pretty good at treating OSSN, but mucoepidermoid is like kryptonite. It can go through, number one is an opening that someone has made, like a cataract surgery or a corneal transplant, but it can also, mucoepidermoid just go through normal tracts that the eye has. So the take-home points here are, consider neoplasia in any case of scleritis, uveitis, sclerokeratitis of unknown etiology, because it can fool me. Intraocular inflammation should make you worry. And always send pathology, because up to 15% of patients may have some neoplasia. So remember, humility is only one patient away. Thank you all very much for your attention.
A couple things to point out. I think in your differential that ischemic necrosis, the patient had pterygium surgery elsewhere, and radiation was used commonly. We picked up patients who had radiation in the 70s and 80s. Often the necrosis occurs like 10 years after, right? It gets this ischemic necrosis that's, and you don't kind of equate it with what happened a decade ago. So that, and certainly radiation, especially the way it was done before, you really couldn't control the dosage of how they irradiated the eye with the plaques they were using. The other point to make is, do you know what the immunosuppression and how long for the renal transplant?
Well, he was on renal immunosuppression at least 10 years.
So one of the biggest long-term risks of chronic bone marrow suppression, with most likely was on mycophenolate, I would guess, is secondary squamous cell carcinoma, and we've seen it certainly in the skin, but the ocular surface. And so it really predisposes patients to develop secondary cancers, skin cancers, and ocular surface cancers, and that's definitely something we all have to be aware of, because we're seeing more and more chronically immunosuppressed patients. Any questions? A very good case. Wonderful. Thank you. Marjan, your mystery case.
Yes. I feel like this panel, the theme here is this a pterygium or is it something else? So we'll continue along that theme. I think, do we have a clicker? All right. Awesome. Thank you. All right. So here's our first case of a quote-unquote double pterygium. This is a 54-year-old gentleman. And he came in, he said, well, he had laser vision correction in both eyes a couple years ago or a year ago, something like that. 3 months after that, he developed this double pterygium in the left eye only. I said, well, what kind of laser vision correction did you have? These don't look like typical pterygium. Do you guys think this looks like a pterygium? Any thoughts? Mark, since you opined on our last pterygium case, what do you think about how these look like? Is this PHSCD? Could be.
It could be after Ed's presentation. The things I don't like about this is that they're almost equivalent in their size. Most double pterygia, one will be dominant, the nasal one, and then the other side would look less. They're awfully flat and they're awfully wide, coming off a very large area. And the question we'd have is that how long has this been going on? Has he seen progression over decades, or has he seen progression over just months?
Yeah, so his laser vision correction, I think, was about a year ago before he presented. And then these developed only in the left eye 3 months before. And if you actually look at his superior, so this is nasal and temporal, superior and inferior limbus doesn't look all that healthy either. So I said, well, what type of laser vision correction did you have? His right eye, which looks perfectly healthy, had LASIK. His left eye, I guess the cornea was too thin, so it was a PRK with mitomycin C. So I said, well, I don't think this is a double pterygium. And this is most likely, any thoughts? Yeah, so this is limbal stem, yeah, mitomycin C related limbal stem cell deficiency and secondary conjunctivalization here.
But let me just stop.
Yeah.
Again, what's atypical is the 3-month. We see a lot of, mitomycin does the same thing radiation does, kills DNA. What's really bizarre is how fast and symmetric this went.
And why only nasal and temporal?
Well, superior and inferior doesn't look all that great either, but you're right. It's mostly the conjunctivalization is really. So I'm not sure if they did wash off the mitomycin C, if it wasn't well controlled as it was used, but this was very rapid, yes.
My question is about the concentration of mitomycin. Sometimes they mix and then they dilute the MMC into the office. And if you do it wrong, by mistakes, this is what can happen.
Great point, yeah, great point. So what would you guys do? So let's take a vote. Should we just take these off and maybe put some AMT on there? There is probably some healthy stem cells in the superior and inferior area, but not a lot.
Did you, what was the fluorescein staining pattern? Was it 360?
Very good question, yes. So the fluorescein staining pattern there was some healthy areas coming from superior and inferior, but not a whole lot.
Okay.
So, yeah. Would you do AMT on this? Remove this and maybe just put AMT and hope? And it could be that the inferior and superior stem cells that are healthy come in and take over. But I feel like we really lost the barrier effect that the stem cells provide in those areas.
I mean, for me, there's a lot of real estate that is not in good shape. A lot of homeless, so I would, if he was amenable, take some cells and recommend a SLED with AMT.
Okay, so, all right, so let me just go through these. Excision, we could use more mitomycin C. I don't think anybody wants to do that.
Let's be. You want to get a 360.
Do we want to use a conj autograph and use the same eye? I also didn't think that was such a good idea because we didn't want to take any more. Or the other option is to take some healthy stem cells from his good eye, which is very nice because the other eye had LASIK, perfectly healthy limbus, and then, the need for immunosuppression is less. Now,
can I vote for something else?
Go for it.
Well, first of all, it's 3 months.
Yeah.
I would do nothing. I mean, this is, I have no idea how extended this is going to be. I want to watch this eye until I know the eye has reached its worst.
Well, this is a year after, but they developed 3 months after the surgery. But yes,
so it's
already been long-standing.
So I first would follow the patient to make sure there's no progression. What I worry about with mitomycin is we're going to start seeing ischemic necrosis, like we were concerned about Carol's case. And the last thing you want to do is operate an eye that's going to develop ischemic necrosis, because any surgery is going to make that potential worse because you're exposing it, you're increasing inflammation. So when I think it's mitomycin with limbal deficiency or with radiation, I watch him for a long time.
Yes, so he had been about a year out and mostly stable at this point.
Besides that, I agree with you, Ed, but I would also hit him hard with steroids. I think you get a lot of progression of all that inflammation right off the bat. And I'd see how he does over weeks and months even of steroids to quiet that eye down as much as possible. And you may find that it doesn't look so bad. Now, the topography is going to be horrible with all that extension. But you don't want to operate on a hot eye like that.
Yeah, so he had been watching this for about a year. He had jumped a couple times around and he had been sort of watched, but not on steroids. That's a good point. So what we decided to do, though, in this case, is we needed conjunctiva to reconstruct. I'm not a big fan of SLED because I don't think it was mainly it was a limbal stem cell issue, but again, we've lost that barrier effect from the limbus. So I wanted some more robust tissue to reconstruct the limbus of that eye. So let's see. My video was running earlier and is not now. All right. Well, that's okay. That's okay.
Let's see if we can continue with. So let's talk about why CLAU is better than SLED for this case. Actually, almost every case, but let's talk about this case.
Yes.
So first of all, there's extensive limbal deficiency, and SLED you're going to take 1 millimeter, and then you're going to chop up those cells and kind of destroy the limbal niche. And if Ology is here, he's going to talk sometime this week about how important that the anatomy of the limbal niche is to grow stem cells. So You can't get that with SLED. And there's conjunctival involvement. And if we look at the most common reason why we see SLED performed is unilateral chemical injuries. They all have conjunctival involvement. So the conjunctival piece that you're harvesting along with the intact limbus is why this procedure is so superior to SLED. And in our area, what I'm seeing is the first SLED fails, they go to the donor eye, take a second SLED, it fails, and they do a third SLED, and now the donor eye has limbal deficiency.
Yeah,
so this is a wonderful operation that's not done enough.
That's absolutely right. So this is and again, for all of those reasons that Ed said, it keeps jumping to this. So what we're doing, I could just talk through it, but I do want to get a nice large piece of conjunctiva here because I do want to reconstruct both sides. You could choose to take two pieces. I took one larger piece from his healthy eye anyways, and I reconstructed, and obviously we don't have to immunosuppress this patient. He looks great years out with a minimal topical steroids post-operatively. But I agree, with SLED, I don't think we're going to get enough robust tissue to reconstruct the limbus, but also we waste that stem cells that we get from the donor eye. Here's another case. So is this a pterygium or not? This patient says, well, her pterygium came back, 32-year-old woman. 6 months ago, she had a temporal pterygium excised from this area. Now it's recurrent over the last 3 months. And her biggest issue is that she has double vision on her left lateral gaze. And here's what it looks like. When she tries to look to her left, the right eye is tethered back and is not able to move. So is this, and then you can see sort of the area of her lateral canthus there. So is this a pterygium or not? Any thoughts? Panel or audience? No symblepharon in the other eye. This occurred directly after this pterygium was removed on this side.
So my guess is there was probably some exposed area that healed in with fibrosis, not normal conjunctival epithelium, and this post-surgical scar involving the lateral canthus and possibly the lateral rectus, which is causing this.
And is the patient keloid former too?
That's a good question. I don't know if she was a keloid former. This was her one and only surgery, and she had no other, history of aggressive scar formation. But in Southern California, we see this quite a lot, actually. Pterygiums that are removed, and the recurrence is not so much the elastotic degeneration that's typical of a pterygium, but rather more of a symblepharon appearing thick fibrovascular membrane that tethers the globe. And so I now have a series of these patients who come in mainly for double vision, whether it's post-pterygium or post-trauma. And these are essentially recurrent or symblepharon. And so, what can be done in these cases? And sort of through a series of frustrated cases, I sort of came up with a specific technique to reconstruct these. But I tried excision with AMT, and they all recurred. I tried excision with conj autograft, and many of those recurred. It was really not a robust enough tissue. Taking tissue from the other eye is sort of the same as a conjunctival autograft, doesn't do much. And finally came to this technique of using sort of keratolimbal allograft or donor corneal tissue to reconstruct these areas. So this is not this particular case, but a representative one where we take down the symblepharon, and Ed Holland has taught me this technique of preparing keratolimbal allograft tissues, but thinning out these keratolimbal allograft segments so that there's a smooth transition from the donor to the host, but essentially using segments to as spacers, really to prevent refibrosis over the ocular surface. And so in this case, we actually used 3 segments sequentially, as you can see. So there's one at the limbus, one beyond that, and a smaller one deep in that lateral canthal area. And she has resolved globe restriction, resolved diplopia here. She has full range of motion. Now her lateral rectus was fine. It was really just the symblepharon that occurred over that area. And so again, pre and post resolution. We've done now a whole series of these.
What
Yes.
do you do with the mitomycin?
Oh, yeah, I do inject a very small amount of dilute mitomycin into, not on the free sclera, but into the lateral canthus where that fibrosis initiates from.
What concentration?
0.02%. Very, very low concentration. And I do about 0.01 cc's. So here's one of our early cases. And again, we put 3 segments on her. She had a small recurrence to the edge of the last segment with a little recurrence of her double vision. We went in and put a 4th segment in, and she had complete resolution. Again, that's a video showing she has full range. She's about 10 years out now. And as you can see, even out at post-op year 2, the cosmetic appearance, those Carey-Lau segments, you don't really see them at all. The cosmetic appearance is actually very, very good. This is a patient post-lid surgery or lid laceration with restriction to down gaze who had keratolimbar allograft reconstruction and had resolution of symptoms. Here's another patient, again, lid laceration. But the majority of these are post-pterygium. This is another post-pterygium patient. You can see that thick symblepharon formation really actually pulling his lid in. So even on primary gaze, his eye is tethered inward and has double vision in primary gaze. Full resolution with a single segment here.
Do you have those patients in immunosuppression?
Very good question. I always get asked. So most of these patients, I do topical immunosuppression, only steroids. Only if they're having a very significant inflammatory response, I may do some oral steroids as well. But again, because it's really for the mechanical deterrent.
I think it's a beautiful technique, and I applaud you for really coming up with it. And it's like the fibrosis on some of these recurrences is so extensive, it just pushes away a conj graft.
Yeah.
Like that, there's not enough tectonic strength to the conj graft. And KLAL tissue is strong, firm tissue. And cosmetically over time, the tissue kind of thins and you get a normal epithelial appearance, and cosmetic is very acceptable. So I think it's a great technique. I think more people should think about it.
Well, thank you. I learned that from you. So yeah, these are a really robust tissue alternative is what we're using it for. It's a mechanical deterrent. So yeah, thank you so much. You have the cloud video. Okay. How do we get there now? Let's see. There we are. All right, so this is that cloud technique again, because I wanted to get a larger piece of conjunctiva here. You see, we can go in further. Again, Ed Holland taught me this technique, but really to dissect further 1 millimeter or 2 within cornea to be able to capture the stem cells in that niche. And then we brought it over to this eye, removed these 2 areas of fibrovascular encroachment of this tissue. Again, I think if you leave these with nothing or AMT, the risk of recurrence is high, or that they would rescar. So we were able to take that single segment that I took, and I actually cut it in half and used both segments and then filled in gaps with AMT.
Yeah, beautiful.
So we didn't have to take more than about 3-4 clock hours from the other eye. And then we shared it across the 2 eyes, the 2 sides of the eye.
I mean, as I said, this operation is so superior to SLEP. This had a lot of conjunctival involvement, right? And every time you read a SLEP paper, what's in the first paragraph? The high risk of limbal deficiency in a donor eye is why we chose to use SLEP. If the donor eye is normal, there's not been a single case in the world literature in which harvesting CLAU, the technique that Marjan just described, has ever caused limbal stem cell deficiency. And so we can't use that as a reason why we refer to SLEP. But the reason why people choose SLEP is they don't want to operate a normal eye and take that piece of tissue. It's very safe. It's much more effective than SLEP. And so another good case.
Absolutely. Thank you.
Great. Final case?
So first of all, I want to reassure you, I'm not going to talk about pterygium, okay? So I'll try to show a difficult keratitis that I have dealt with. So this is a case of 34 years old woman in good health, and she is a daily contact lens wearer with a recent ocular history of 3 weeks of red and painful eyes. So she was at different hospital, and they said, okay, you have herpetic keratitis, so start the treatment with acyclovir 400 milligrams 3 times per day, plus chloramphenicol and steroids drops 4 times per day with no improvement. So she came to my clinic, and this was the picture. I don't know if you can see, apart from the intact epithelium, there's a little ring here with some infiltrate. So question number 1 for you, what would you have done? Stop the treatment and wait to see what happened? Start anti-amoebic treatment because there's somehow a ring shape infiltrate? Start intensive antibiotic therapy, or performing a corneal scrape despite no epithelium defect? So anyone with a microphone there? Lucia, if you wanna first stop and wait. Okay, so anyone that wanna add something? Otherwise, probably is a little bit long this case, so I'll go further. The next slide. So I decided to perform the scraping, and I decided also to do something and not just performing the scrape and wait. So do you have any advice on what to start on this patient? Fluoroquinolone plus aminoglycoside, only fluoroquinolone, PHMB, or no treatment, waiting for the results? Luigi, you are in the first position. PHMB, okay. Anyone is taking any offer? Marco, what would you choose?
Were you able to get a
I would try
confocal by
to-
chance?
No, unfortunately, I don't have confocal close to my hospital, so I didn't perform at this stage.
Yeah, because I was going to ask the same thing, but maybe at least to know how deep were those infiltrates, whether they were superficial or...
They were around 200 microns. Because I did the OCT, I could see it. Sorry, I forgot to make the OCT picture.
And which treatment was she doing before?
Steroids plus chloramphenicol. So I performed the scraping, and I start just fluoroquinolone and aminoglycoside. It's something that I always do because we can have different infection that can be acanthamoeba, fungal, anything, but also we can have polymicrobial infection. So when I perform corneal scraping, I always start antibiotic drops for some time. And then, so I did the corneal scraping, started empirical treatment, and then I reduced it without stopping the steroids drops. So I went from 4 times per day to 2 times per day, and I was waiting for the culture and the PCR for HSV and acanthamoeba. And after 5-6 days, the patient came like this. Okay?
Did you do any smears from the scrape?
Unfortunately, I don't have these facilities. I wish I had it in my hospital, but still, I mean, microbiologists, nowadays they say, no, we don't do it anymore. So I'm trying to deal with the pathologist and try to set up the smears. So let's go ahead. So the results are in Italian, but we can see HSV is negative, and then we have the PCR for acanthamoeba is negative, and the parasitologists from my hospital, they are very good, so I trust, together with the virologist, so no bacterial grow, and I'm waiting for the fungal. And this is what happened after only 7 days. That never happened to me, because usually I have to wait like a couple of weeks, but after 7 days I had this grown on the suboral plate that we know that is specific for fungal. And also at this point I asked the microbiologist to do a picture, and this is what came up. Okay, so you can see that is filamentary fungus. And do you have any advice on what to start? So natamycin only, voriconazole only, voriconazole oral, or all of the above?
Why not do all of the above?
Yeah, correct. I wanna just shot all my bullets. So this is what I've done. I started everything, and then I had antimycogram, and I saw that voriconazole was good to treat this Beauveria bassiana. Actually, it was not a fusarium that is much more common, but it was a Beauveria bassiana that is still a filamentary fungus. So after 12 days of treatment, still epithelial defect and still infiltrate. So what to do to increase the efficiency of the treatment? So adding local antiseptic like chloride or povidone iodine, increase the dose of medication. Actually, when I prescribe natamycin and voriconazole, I go every hour for a week, and then every 2 hours until the epithelium start growing up. And the first 2 days, I tried to ask the patient to use it at night time as well, because natamycin is quite a big molecule, so it's difficult to get inside the stroma. So this was the regimen that I prescribed.
Had you stopped the steroids at this point?
I reduced it, but I continued for another 5 days, and then I stopped it. Because I'm always scared, because that reaction from the 0 to day 5 was, in my opinion, was from here getting here was because I stopped, I reduced the steroids. So I didn't stop at this point. I carry on for another 5 days, and then I reduced once a day for another 5 days, and then I stopped it, because it's well known how the steroids, stopping the steroids can induce a melt. So I stopped it at day 12, but in 10 days.
Are you considering a DALC at any time soon?
No, at the moment. The fungal infection is the only case when I consider to do a surgical approach. Actually, my point was waiting a little bit until I could see some deterioration close to the limbus. If this lesion would have done a little bit further in peripheral, I would have done surgery, definitely, because I'm scared about going into the sclera or going into the anterior chamber, but was not more than 50% of the OCT infection. So this is why I did not operate this case. So adding local antiseptic, increasing dose of medication, more than one every hour, removing the corneal epithelium, none of the option. So probably would have been surgery.
I'd be calling the IBA.
Surgery. Sometimes when the infection is very central, and we heard Enrico give a beautiful talk earlier, but when it's very central and before it gets to the point where it gets close to the limbus and makes keratoplasty more difficult, doing an earlier keratoplasty or DALC may help.
Yeah, I fully agree, but again, my cut point is that how far is from the limbus, and I thought that was still okay. I started to see the patient a little bit more frequently. So what I decided to remove the epithelium to increase the penetration of natamycin and voriconazole. Actually, the first time that I did it, I sent to microbiology, and again, Beauveria grew up on the plates. So it means that, okay, probably this treatment is not working a lot. So what to do next? Continue the therapy, perform the PK, again, add local antiseptic, or voriconazole intrastromal puncture. Luigi said the fourth, Dr. Terry.
I would have done the voriconazole intrastromal injections earlier.
Yeah.
Because I think that we have an opportunity to really get concentration to the patient. Now I'd like to do OCT and see how deep you are. They should have thrown this to me a second ago. I would get an OCT and see how deep you are. We're worried also about it penetrating through Descemet's membrane.
Yeah.
Because it can grow right through.
Luckily, it was always between 50 and 60% of the corneal depth. So I decided to perform, I don't know if you can start the video, but you know how to do it in intrastromal puncture. Just pedal down and start the injection. Ok, thank you very much. But non è possibile riprodurre il video. So we can go ahead. So I did, I started the intrastromal puncture and then I repeated 3 times in 10 days. And I had a massive improvement when I started doing the intrastromal body-corneal injection until everything was quiet. Yeah, this is the video, but we are running a little bit late, so just to try to edemize the cornea, bevel down and try not to go inside the anterior chamber, but differently compared with the mitomycin when you use it sometimes for mice surgery, even if a little bit of voriconazole goes into the anterior chamber, nothing to be worried about. So I performed 360 degrees around the lesion. It's not working the remote. Probably because they... Okay, so after I thought it was resolved, I don't have, sorry, I missed some picture. I saw some pigment from the center of the lesion. At this point, I thought, I mean, just before the pigment, at this point, before the pigment appeared, I said, okay, I've resolved, so I can plan a PK in or a talc in 6 months. Or even more. And then I started to see some pigment. Just to remind you that the fungal can be divided in yeast and filamentary fungal, and the filamentary fungal can be divided into fungal that can produce some pigment and fungal that they don't do it. So when I saw this pigment, I said, probably some recurrence, but it was strange to me because I thought that everything was ended. I don't remember actually if the patient was still on, she was still on voriconazole, so I decided to increase the voriconazole drops. And after 10 days, this is what happened. So there was a perforation. So I managed with the glue patch, with the cyanoacrylate glue, and finally I ended up with a corneal transplant. But it was not in hot eye because this was around 5 months after, 5 or 6 months after the beginning of the case. And I treated again with cyclosporine, not steroids, natamycin and voriconazole, but no recurrence, and this is the end of my case. So, probably the only things that I want to add, because I forgot, what was that pigment that I saw in the beginning, and this was advice that gave me Professor Nubile from Chieti, and he said probably there was a tiny small hole that you could not see any frank leakage, but only a oozing or something like that, and that was like pigment from the iris that from the anterior chamber was going depositing there, and this is why I saw pigment. So it was not pigment from the fungus. And I like that idea. So.
Yeah. Very good. Good case. Thank you for the panel and the interesting cases discussion, and we move on to our next section. Wonderful.
Thank you very much.
That was good. Oh, 15-minute break, I'm sorry. Okay. Followed by live surgery by Professor Sarnicola.
Io ho chiesto,
Es que hay una que sí.
Perché lì invece va bene, è qua che non va.
Primero se pide. Es que la revisión pasado.
Nino!
Pues, pues nos vemos, sí que nos vemos en la entrada. 7:25. Y ya nos vamos. De eso, ¿en qué momento te preguntabas qué coño hago y qué coño me ha mandado a venir aquí? Aún así está bien. Yo por lo menos me había un minuto esperándome. ¿Ah, sí? Sí, yo venía antes en el Congreso que me estaba esperando y me escribió, oye tío, que está tratando de horas y menos cuando llegué a las 11:30 de la noche yo también podría hacer esta cuando le no sé, vuelve a ir, pues ya se lo mandan al servicio. Y ahora pues, a lo de postura, la cuestión es que la chica entonces ahí no había visto y era mi cuerpo subido, así que estaba se ve que la había visto viene, ya llevaba 2 semanas. Le pones un sobre, muy contento. Claro, o sea, las fotos las escribís, ahora le puse al SICSSO y creo que la volví a ver más tarde y así suele. Estoy una semana la chica está la piel de la rebajada se ve función y entonces la vuelvo a ver. La cuestión es que yo la sigo viendo la chica bien, y simplemente estaba nada. Es que está todo total. Todo. Yo todo lo quisiera hacer, lo quisiera ayudar. Coño, es perfectamente aprendido, lo que vamos a hacer. ¿Ves todo esto? Esa pega diseminada, esto es todo. No vuelvas a hablar de eso. Y la madre le dice, no, que no volvemos, que ya de aquí no vais a volver. Y la madre, ¿por qué solo dices tú? Vale, ¿vas a ver a tu hija? Esto es como ver a tu hija. Sí, y la cosa le comenta a la profesora. Tal cual. ¿Sabes cómo se llama la chica? Unidad. Hay un orgullo.
Sí, sé que, bueno, a mí me ha preocupado, o sea, digo,
es que tiene que ser, pero bueno, es que se le da, mira que el tío es bueno, lo has visto, el tío sabe, pero es que se le da la puerta a otro, es tan orgulloso que llega a tal nivel de orgullo que le ayuda, que comete errores solo por uno. No se puede parecía que yo, Víctor de Certongas, con todos los tíos, ¿verdad? Oye, coge este teléfono, oye, Víctor, tal, que he recibido a esta paciente, vamos a ver, no sé qué, colaboramos, pacientes que vienen, que van allí, que vienen aquí y tal. Que nos está desarrollando esa posibilidad de paciente. Quiero que sepas que no vamos a hacer esto. Entonces, o haces lo que yo te digo, te vas de ahí, o te quedas allí y yo no te voy a modificar nada. Porque como digas allí, y si no te lo digo, y si alguna dice nada, te digo, no digas nada. Digo, porque te van a maltratar. Claro, porque ha habido ya los
claro, yo el tema clínico del día a día
que uno no termine la residencia de es un requisito para la residente de allá. Si no te ha hecho llorar, ¿sabéis? Es que yo no he tenido pero es verdad que es una persona que la respeto, pero que ahora tendré que trabajar con él, no lo sé. resumo.
Venga.
Ahora te veo la vez. Ahora te veo.
Oh, mi sono vestito a merda perché non stavo vedendo la casa qua, la stanza qua, il territorio fazione non ce ne costa. Dall'altra parte c'è rimasto così. Io pure, infatti volevo dire,
Mi hanno dato la stanza invece alla
Okay, friends, if we can have a seat, we're
volevo
going
dire, non mi
to
fa
jump
fuoco,
into
sono così.
last and best section of the day.
Sono schiano,
Very interesting
sono dodo
session
schiano.
on what's new in the field of corneal therapy. And of course, we're going to start with our live session, our very own Dr. Sarnakola, who is going to jump in with a live surgery for DALK. And so there he is, and we'll go ahead and turn it over to him.
Good morning, good afternoon. Can you hear me?
Yes.
Perfect. So, good afternoon to everyone. Here we are in the Clinica degli Occhi San Nicola. Professor Vincenzo San Nicola is doing a surgery on a patient with advanced keratoconus. The patient is a female, 21 years old, and in the right eye has advanced keratoconus. As you can see here, the eye has been treated with peribulbar anesthesia, and now Professor San Nicola is going to center the center of the cornea in order to guide the trepanation that he will going to do it. Regarding the keratoconus that you are going to treat is an advanced keratoconus, and with very thin cornea, it's 379 micron in the thinnest point, with a K of 53 and 61. So it's quite advanced keratoconus, does not have any scar, as you can see. And now we are going to proceed before with the titration that he performed with some guidance to see is a 5 millimeter mark, and then we are going to see now the center with the caliper. In the cornea the patient has a very good endothelial cell count. It's more or less it's about 2,800, and so the aim is to do a deep anterior lamellar keratoplasty, and Professor San Nicola is going to do downswings with the pneumatic dissection. So try to do a big bubble. So we are going to do a trepanation of 8.5 because a professor checked the size of the cornea and the overall cornea and see which is the best fit for it. So
this is 8.
Sorry, this is 8 as you can see. So probably 8.5 will be plenty. Will be plenty, giving a better visual access to the patient. So it's quite large. And the advantage to have a large duct will be for the patient because the patient will have less astigmatism, so there will be less problem after the surgery, of course. So as you can see, there is some the pupil is a little bit dilated, a little bit due to the peribulba that she had, plus use some guidance in order to procedure for the big bubble dissection. Now we are going to do a trepanation, as we said, 8.5. The patient is very, so she doesn't have any problem. She's been treated with peribulbar anesthesia around 20 minutes ago. So now the eye is completely blocked. He is going to, as you can see now, he's centered. And then now he's going to put this trefine and and there is a suction. So the suction got it. As you can see, the confirmation comes from because the trefine is it's very stable on the cornea. Now it's going ahead.
This is one.
This is one turn.
3, 4, 5.
So Professor San Nicola is counting.
7 and 8.
So he does 8 rounds. That if you see the 8 round, and if you see the cornea in the periphery, the thickness was around 600 and between 600 and 550. So it's in order to have more or less 2/3 of trepanation. Okay, now it's going to perform to dry a little bit the surface to see the where was exactly the cutting, and to check the bed where it's going to where it's going to do a tunnel for the big bubble for the pneumonia section. As you can see, this kind of instrument is quite blunt, so you can see that it's in the right space because he advanced quite easily. So this means that the definition was very good, very neat, and so as you can see here, compared to some other technique, he used this blunt spatula to make the tunnel. This makes more secure and probably easier to see which is the best place to go. So this cannula he designed himself, and I think I need to say that it's very useful. It's very useful because help you a lot in these cases because it's quite smooth. Now he went in with a cannula, 27 gauge cannula. As you can see, there is a bubble. So that's that's a very big size bubble. As you can see, a bubble type 1. So it's you can see that this means that he was in the right depth with the cannula, and the cannula and the pneumonia section came quite easily. now he's going to do a lamellar dissection on the top, and then he will do a brave slash after that. This means that he will have he can get this this dips for the dog will be quite straight, quite good, because it means that the bed of the dog will be uniform and quite good. So as you can see, he goes with the crescent blade and then going from one side to the other. The white of the tissue he will guide to perform this step. This step is just to reduce and to facilitate to facilitate the brave slash, to facilitate the stromectomy, because this way the stromectomy will be easier to cut. As you can see, the patient is quite calm. Here the clinic is very good. It was the first time for me to come to the clinic here in Grosseto. It's in the middle of Grosseto. It's quite big, and there is 2 theaters here, one close to the other, that make the patient quite comfortable. I need to say also the surgeon, and for me as well. So now is nearly finished the superficial stromectomy, and soon he will use viscoelastic on the top of the bubble in order to get to make easier the brave slash. So you are going to use a viscoelastic on the top of the bubble in order to reduce the pressure the air coming out from the bubble. This way, the risk of perforation of the descemet membrane is less. As you can see now with is going to do this an MVR blade. This MVR blade is a 1.1, and is going to open the anterior chamber in order to reduce the pressure. As you can see, he oriented the VR blade in the periphery because he doesn't want to risk to touch the big bubble, okay? Because the big bubble, the inner layer, is going down in the anterior chamber. This maneuver is going to reduce the pressure in the anterior chamber, and not just reduce the pressure, but also avoid that the air will come out very quickly from the brave slash. He used some Michael to reduce the chamber, to reduce the mydriasis, and he's going to put now a viscoelastic. This viscoelastic is a cohesive viscoelastic that is going to be on the top of the cornea. Professor San Nicola, as you can see now, he's going to do that, and he's going to do with a blade that is 2.4. So it's the normal blade that normally we use even for cataract surgery. And you can see, so it's quite big. He used that one because the 2.4 make a very good entrance and reduce the chance to have a complication, to don't find the brave slash. As you can see here, as you do cataract, you do a tunnel, and you need to. You can go in and out. You see was quite safe. And now it's going to use BSS in order to wash out the visco and look for the interface. is going to replace the air with a viscoelastic.
No, this is visco.
It's going to replace the air inside with the viscoelastic, or probably there is no air anymore, but it's going to put viscoelastic in interface. As you can see, there is an interface in order to avoid that, the desmet is close to the stroma. With the spatula, it's going to check to reduce the pressure in the anterior chamber, and in order to reduce reducing the pressure, the risk of the desmet, the complex desmet endothelium coming out is less. And now it's going to do the stromectomy, making a cut. This cut, of course, is let's say in 4, like a pizza. He's doing a stromectomy that in order to make 4 slices, and then he does from the center to the periphery. Some air is still coming out. In case normally this is the first approach, the best approach. So doing a talk, of course, the big bubble is the quickest way to achieve a deep layer for a talk. But in other cases, you could do also a peeling off technique in case of unsuccessful big bubble. The peeling off, just to remember that it's been described in 1966 by Eric Malbram. He's an Argentinian ophthalmologist that has been president as well of the Ophthalmology Society in Argentina. He's well known, still working, and he described this first technique of peeling off. It's been described later also, this technique by Professor San Nicola in a way that is a spiral, so going from the periphery to the center. So going round and round. The more round you do, more easier to get in the best dip to perform it. And you can see now here we don't need to do this technique of peeling off, but here with the big bubble, you can get a very good plane straight away. The stromectomy, it doesn't need to be, so it needs to be the best way. You can cut in the different shape as you like. We are doing some shape in order to make it easier and to perform the total stromectomy. Stromectomy usually is same size of the bubble. As you can see here, you will have some viscoelastic, some small bubble remaining in the interface, but we are proceeding very safely in order to see if the periphery is how big is the periphery, how confident we can be with the scissors. We are going to check with the spatula how big is the bubble, and before to do that, we are going to reduce the pressure inside of the anterior chamber. Because it's quite crucial to reduce the pressure, because if you reduce the pressure, then you can do this movement. That means that cutting the stroma more safely, and you have less chance to have a peripheral perforation. As you can see here, it's quite safely it's going to periphery and removing the stroma. That is just the good guidance that it's all white. It's white because there is air inside, and is exposing let's say the layer, the dual layer, in the best way. So now we are going to proceed to do a stromectomy all around, and after that we are going to suture a cornea on the top. If there is any question from the audience that I can help you to answer.
Any questions? Do we have our ball still? If
If
we
you
have
can
a ball, I can toss any, if there's any questions. If there's, I have a question. If there's any perforation at this point in the periphery, how does that get handled?
So I think
Can you say the term from Naples?
So I think Professor Nicola is me as well. We both come from Naples and we are very superstitious. So I think this question probably will answer later. But just in case you want to know, there is always the same. So small perforation can be managed. Also big perforation can be managed, but would be better if not happen. But anyway. The perforation, if you reduce the pressure in anterior chamber, you keep the perforation small, and you try to carry on what you're doing and limit your the problem. If you have a small perforation, especially in the periphery, should be not a problem. You need to leave a big air bubble in the anterior chamber and carry on with your transplant. Normally, when we do a doc, I think Professor San Nicola described as well a very nice technique that he normally uses a suture, that single suture, because in case of double chamber, is able to manage better the double chamber, because sometimes you need to reopen the suture, and you can manage a different kind of perforation, a different kind of anterior chamber. As you can see, is doing a stromectomy all around in a spiral way, and he in the center is clear. Now we know very well that the stromectomy need to be. So the most important one is the center. Even in the periphery, there is a little bit of stroma left. Does not matter. The important is exactly to clear the center. It's been described also this bubble that are 6 millimeters in the center, not in the. So there is some stroma left in the periphery. It's not a problem. And after that, is proceeding in this way. Normally, you go and you reduce exactly the pressure in the anterior chamber during the movement that you done before. So with the cannula. As you can see, as soon as you have some opening, then he goes all around, and this is quite good. And then you can perform this thing with a scissor. This scissor is especially for dog, because it's rounded on the let's say on the descent side, and this make everything safer.
What kind of anesthesia is being used?
So the anesthesia that he performed anesthesia that is peribulbar anesthesia, was done half an hour before, more or less, and then he gives pneumo-ocular, so some pressure on the eye. That this pressure is below the pressure of the minimal of the patient, so under 50 millimeter of mercury, and so it's just peribulbar anesthesia. Peribulbar anesthesia with the two kind of anesthetic, one bupivacaine and carbocaine. And it's peribulbar, and the patient is it's very compliant. She's very good. She's okay. She's 21 years old. Sometimes it's quite difficult to manage these patients because sometimes they don't respond very well. But I need to say that here is treated very well. There is a big kit here, a lot of help from anesthetic doctor and nurses, orthoptics, and all the team from San Nicola team. And here we are, as you can see, the 8.5 millimeter was the right size, because make a quite good a quite good cap, and nothing.
This microscope is very.
Here we have a microscope that is from Luxor Revalia, and it's a floor microscope, so you can move quite easily. You can change different setting on the magnification, of course, light, focus, and it's quite. You need to adjust sometimes. So you need to adjust the reflex, because in the beginning there was some reflex that it's been adjusted, but I hope that you can see quite well from from there, right? Well, is okay? Can you see? Yes.
Can you say that this is the right way to cut the brief?
Yes.
With the vertical SICSSO.
So that's quite important point, a learning point that I think is very important, because if you cut in that way that is vertical, you reduce and safely avoid the perforation in the periphery. Because if you're going to do the normal way that you do in the penetrating keratopathy, so means you're going to put the S.I.C.S.S.O, under one blade under the, let's say, the stroma, you are going to increase the pressure, have chance to have this small perforation. This way, so you need to do two movements. One is to reduce the pressure in the anterior chamber in order to reduce the way that the complex descent endothelium is coming out, plus do this cutting in the vertical way. This cutting vertical way avoid any pressure on the descent, and it makes you quite precise to perform it. You can move the eye as well, as you can see, and this makes you quite easy to access, do the stromectomy.
Especially here, where the stroma is not dissected by the air.
And as the professor was saying, in this way it's very useful, especially where the stroma is not completely dissected. And so I'm going this way is going to reduce the pressure on the descent membrane.
And this is the area where it's very easy to break and cut the descent.
Exactly. So I don't know if you heard it, but if you do this wrong movement, this is a high chance that you're going to do a micro or macro perforation in the periphery. A micro macro perforation in the periphery is not possible to. So means that not make you don't carry on, but if you don't have it, it makes much easier the follow-up and the recovery of the patient. As you can see, here exposed more or less two-thirds of the descent membrane. So bubble type 1 with the dual layer exposed. And here we are going to finalize this in this stromectomy very soon. We are going after to prepare a tissue. The tissue comes from the bank, the eye bank of Lucca, that thanks to they helped us to have a very good tissue here. And I think this tissue is a double check. This tissue should be a tissue for PK, and then we are going to remove the endothelium. As you can see now, the stromectomy is finished.
Yeah.
And we are going to place the. Okay.
This is wonderful. Thank you so much. And do you do a?
You're going to carry on with some talk. Is that right?
Yes, we're going to carry on with some talks, and thank you so much. That was a beautiful dissection.
If you have any questions, please let us know. Otherwise, we are here for you. Thank you.
Wonderful, thank you. And so we have an amazing panel here. We're gonna really jump into talking about some therapeutics in cornea that are above and beyond and new. And I'm joined by an amazing panel, Dr. Sampaio from Brazil, Dr. Anat Galor from the US, Dr. Grau Hernandez from Mexico, Dr. Kostler from the US as well, and Dr. Basu from India. And so we'll jump in with losartan eye drops for corneal scarring. Dr. Sampaio.
Hello. So first of all, thank you so much. It's a great pleasure to be here in this fantastic meeting. So I'm going to talk a bit about the topical losartan. Do you have the slides?
Oh, clicker is maybe it's this.
Oh, okay. So just to start, okay. Talking about the losartan, first of all, I would like to talk a bit about the haze and why it happens. And this is something Dr. Wilson and many of you guys have been studying for more than 30 years, and it's related to the myofibroblast differentiation. And what happened is that when you have an injury, like here, okay, so I'm gonna show later. So when you have the injury, the TGF-beta goes inside the cells and helps the differentiation of this myofibroblast. The myofibroblast has the cells that we can see here, and you also can see in the immunohistochemistry of this red staining. This red staining is SMA, the smooth muscle actin cells, that they represent the myofibroblast. And what happens here is if you have an injury, the TGF-beta that is normally present in the epithelium of the cells and in the tears, they go to the stroma and they differentiate the fibrocytes and the fibroblasts into myofibroblasts. And what is this problem? Talking about the opacity. It's because the myofibroblasts, they do a very disorganized deposit of extracellular matrix in the stroma of the cornea. And if it's disorganized, then you have the scars. So, been studying this for many years. In the lab, we decided to study the losartan. And why losartan? Because losartan is known to be an angiotensin II receptor blocker, but it also has this role of impeding the transforming growth factor beta signaling. So what we thought is that maybe the TGF-beta could be blocked by the activation of the topical losartan. So this is the mechanism we think is the way that it can help to prevent and to decrease the topical the scars in the cornea. So we started doing some studies in the lab. So I'm now based in Brazil. I did my residency and my corneal fellow at Sorocaba Bank under the guide of Dr. Nicholas that taught me about the max and everything. But then I moved to US for almost 4 years to do some research and my PhD thesis about corneal wound healing. And then we started to treat the losartan. So I was leading the first studies under the mentoring of Dr. Stephen Wilson. And the first study we did, I know it's a lot of biology, so I don't want to go very deep, but just to show some studies we did in rabbits. The first one was talking about the decimetorexis. I did some decimetorexis in the rabbits, and we treated with topical versus placebo in oral losartan, and we found out that the topical losartan decreased the opacity. So we had some scars in the bunnies, and also we did the immunohistochemistry to see the SMA. This study was all masked, the immunohistochemistry. And also we just studied for 1 month. So we didn't know if we went further, if we would have like more results. Then we continued doing some studies. We also did some prednisolone versus losartan versus placebo, and prednisolone together with the losartan after chemical burn. And we found out that together they are stronger than losartan alone or prednisolone alone, and because there are different pathways. And then we did irregular PTK, and here, as you can see, we have less red staining in the losartan group than in the vehicle. But we had one bunny that didn't heal and had a persistent epithelial defect. And this is something we're going to talk later about insulin and everything. So if you have epithelial defect, the losartan won't help because the TGF-beta will keep going to the stroma. So you need to close the wound, not only to prevent infectious disease, but also to decrease the opacity. And then we did this study that was PRK. That was the 4th study we did. I did all the PRK surgeries at the Cleveland Clinic in the bunnies. And we didn't treat with mitomycin C because we wanted the cornea of the rabbits to have fibrosis, and then we compared losartan versus placebo. And I won this prize like 2 years ago at the JRS for a scientific publication for young ophthalmologists. And then we did the last one when I was in the lab, that was with acute incisions. And then I came back to Brazil, and then people started to treat about topical losartan in patients. And this is something we're going to discuss today. Because I know it can be a bit like polemic, and also I want to hear from colleagues and from everybody, how are this case going? So we have some cases already published in PubMed for corneal scars decreasing the opacity after the topical losartan use. The first one in the top is a case that a friend, a colleague, treated. Was a 15-year-old boy with herpes zoster, treated before with acyclovir, and it didn't improve the opacity. And then she told me, people refer this patient to me to do a corneal transplant, but it's a young patient, just 15 years old, high risk of rejection, also having a transplant so young. And in the other eye, he had a scar because he had toxoplasmosis in the other eye. So she said, I'm going to give a try. I'm going to try the losartan because I think it's the only option I have now. I don't want to go and do a surgery for this patient. For this patient, after 6 months, the scar decreased, the vision improved, and the patient is happy, the family is happy. I can't swear to God there was the losartan, could be time. So that's what we're discussing here, because we need to have a larger clinical trials to really know. But we have some cases after herpes and late haze PRK that are decreasing. And last week, a friend from Mexico, Francisco Sanchez Leon, sent me this very interesting case that was opacity after inlay. He did some inlays in the past for presbyopic treatment, and the patient has like this scar, very old scar. He tried many things in the past, and then as soon as he tried the losartan, the scar decreased a lot and the vision improved. So I think I really liked this talk shows because I think it's a way to get some information, to be more like discussing with people that have a lot of experience. And I really want to know how the cases are going. I really encourage everybody to publish the cases, even if they're good or bad, then we can know more. But of course, we need like larger clinical trials. And just to finish, just small things about the research we've been doing for almost these 5 years. What my group, Dr. Wilson, and all the people from the lab, what we recommend is, if you want to give a try, you need to first know if it's myofibroblast related corneal haze, because otherwise it won't help. You need to talk with the patient. There is still an off-label treatment. You need to look for a component pharmacy to prepare this medication, because it needs to come from the powder of the losartan. And the dose is 0.8 milligram ml. They tried to increase the doses after I moved back to Brazil. They tried this at the Cleveland Clinic, and there was a bad toxicity in the rabbits, so they needed to stop the protocol. So we don't recommend increasing the doses, and this is still 6 times a day that I know it's very hard for the patients. But it's like this, some patients just take 4 times a day and still have some benefits. And it's 6 months of treatment. Almost all of our cases just got better after 4 or 5 months after the treatment. But the good thing is that it's not very expensive and we don't have any adverse effects related so far. So when people ask me, I really say, I don't know how it's going to be the stock like in 2 or 5 years. But if you don't have anything else to do for the patient right now, maybe it's a try until you do like some other surgeries. Thank you.
I have a question for you. Given the suggested mechanism of action, do you think that it is it sounds like it would be most effective in fresh wounds where you're trying to prevent scarring, but in long-standing scarring, is it as effective? What are your thoughts in terms of, do we treat all scars and see what happens, or is there a certain characteristic in terms of time from wound that's going to be the most effective?
Perfect question. Thank you so much for this question, because in the bunnies we had all fresh scars. Actually, some of them are not even the scars yet. We're like preventing and like waiting to see what is gonna happen after treating. But like as I showed, like the other case with the inlay, there is a very old scar, and he said that the patient has the scar for more than 5 years and was there. And I also have some patients that people refer to me with like 20, 30 after PRK, very mild scar, barely can see in the slit lamp, and then they start to treat with losartan and refer to me, and then the scar decreases, it's 20/20, but it's even hard like to show the picture before and after, because there's almost nothing, but the patient is saying that the halo glare is better and the vision is better, so I was not even sure if it was a placebo thing or if it was like in his mind, or really like got better, because the visual acuity got better for 2020 and it was old scar, like 10 years.
Scars.
Yeah.
Any other experience?
No, I have a question too. Given the safety profile of the medication, do you think it has a role in preventing haze in refractive surgery? So should we start switching our minds instead of using mitomycin and start using?
It's an amazing question. I think so far on the page we are now, we really don't have like some more strong argument to do this as a prevention. But for example, I have a friend here in the audience that he had a patient with a scar after pterygium removal. And then he removed it doing like a epithelial debridement, and then it came again and again. He did it like 4 times. And then the last time he said, okay, I'll do this and I'll put losartan. And then it never came again. So sometimes for this case, maybe you can like do this as a prevention. But I think we need like more data, like more scientific things to really say to this patient why we're doing this. But if it's a case that is like coming again and again, like after PTK, after haze, maybe, I think now that we know that some scars decrease, maybe we could try as a prevention.
Dr. Galore, do you have any experience with this? Oh, Dr. Weston, sorry, I didn't say. Yes, sorry.
I had a question as a follow-up what Enrique said. So are there any clinical characteristics that are indicative of myofibroblast activation? Like, are there certain kind of scars that you can look at and tell, okay, losartan is going to work great in this case?
Can I come back? Yeah. So this kind of haze, when you see this haze here in the first one. So this kind of haze, we really think it's like myofibroblast related, because as you can see, it's opacity, and you have these clear areas between the opacity, that is the lacunae areas. And they are very characteristic for being a myofibroblast. We did some other studies. Also, other colleague that is here did some studies about the perilacan, the epithelial basement membrane, Rodrigo did, and then we can show like exactly the areas that are myofibroblast, perilacan. Also, if you really look like a haze like that, these are the haze that I think, okay, it's myofibroblast related, and we can give a try. But we also have some other opacities that are more dense and diffuse that people are treating with losartan is decreasing.
So are you also looking at like superficial lesions?
Yes, superficial. If it's very deep, I think it's or with neovascularization.
I do have a case to share. I didn't bring the pictures, but it's a fellow of mine did a complicated smile. He got very inflamed. He had an intrastromal scar and improved significantly on losartan drops. Although not completely, but very importantly. So I'll share the pictures with you.
Okay, amazing. I'm very happy to hear, because all the time I hear that a patient got better. I mean, being a scientist, we still need more studies to know. But on the other side, being an ophthalmologist, if we can change the life of one person, it's worth all the work, because it was a lot of work to apply drops in rabbits like all those years. So I feel very happy like when I see some patients improving.
Thank you so much. Thank you. We're going to jump to Dr. Galore, discussion on insulin, eye drops for neurotrophic keratopathy.
Okay.
Can we have her slides, please? Oh, just keep going. Yes, it's one long presentation, right.
Got it. Okay. So this is a conversation about insulin and also philosophy. Okay, so what's the deal with insulin? Before I tell you what I think, I wanted to see what PubMed thought. And it turns out there are a lot of reviews on insulin, actually more reviews than primary studies. But if I looked at the primary studies, most people are using it for neurotrophic keratitis and diabetic dry eye disease. And I have to say that is pretty similar to what I do. When I think about the umbrella of ocular surface issues, I think about topical insulin when I think nerves are abnormal. But of course, nerves can be abnormal for more than one reason, and I like to group it into NK, neurotrophic keratitis, and NP, neuropathic or nosoplastic pain. And so mostly when I think about topical insulin, I like NK. But the philosophy here, and I hope some people will discuss this with me, is what is NK, right? Because it used to be completely ignored. Now we have a few medications to treat it, so now everyone's talking about it. And if you look at the definitions, you need reduced corneal sensitivity, and then we have these grades. And grade 1 is epithelial staining with reduced sensitivity, and that is the group that I really think about topical insulin. But I like to spend a lot of time talking to Tard Margolis and Debbie Jacobs. And the question that keeps on coming up is, are we overdosing NK? Like, not all PE are the same, not all decreased sensitivity is the same. And the question is, are we just being too liberal? Before, no one had NK, and now everyone has NK. So what is truth? So according to Deb, she looks at the location of the PE, and she wants to see that they're central for NK. And Todd Margolis has like 27 criteria, but if I had to pin him down, he likes to see snowflake-like NK. Hopefully you can see some snow in these photos. And so I keep on sending them these pictures, like, what do you think? Both of these people had decreased sensitivity, not absent, just decreased. And they said, well, this one is not snowflake enough, and that one isn't in the right spot. Okay, so let's say that I do diagnose NK, and I'm hoping to have your thoughts about what your threshold is. I have to say that I first use blood products because they're so easy for us to get, and if that doesn't work, then I move on to insulin. The other thing people ask me about is, what about NP? And I can talk to you forever about NP, but I would say that just like NK, there's more than one type of neuropathic nociplastic pain, and it's the peripheral neuropathic pain plus NK that I find responds best to both AST and insulin and oxybate. And so once you have central mechanisms, topical therapies probably are not as helpful in my hands. What's the good news? Just like topical losartan, I am very conservative. I let this guy try everything and then to tell me how it turns out. I'm like a late adopter, and both with losartan and with insulin, there is no safety signal. So I am an early adopter. They have a study using topical insulin for optic neuropathy. They're using 100 units per ml. Nothing has happened. I use 1 unit per ml 4 times a day, so tranquila, no problem. Okay, what are the questions that I'm hoping we're going to talk about? What are the best clinical scenarios where you use insulin? When do you think they're better than blood products? What is the optimal dose? Somewhere between 1 and 100 units per ml is what's being used. What do you do about storage issues? My pharmacy compounds them and says they're only good for 2 weeks. I tell people, put them in the fridge and use them for 4 weeks based on absolutely no data, other than I feel bad because patients have to pay for them. And so thought that these would be good things to discuss, and thanking the organizers for inviting me to this beautiful meeting so my kids and I can enjoy Italy. Thank you. All right, what do you guys think? Insulin. Do you love it? Are you kind of like so about it?
Go ahead.
Audience?
Any audience questions, thoughts? Who is using insulin right now?
Show of hands.
Oh, so there's,
So there are lots of
amazing.
thoughts. We want to hear from you.
We would love to have somebody. There's I can throw a yellow thing at you, but there's the regular ones still. So, because my aim isn't good, I might hit someone in the head. So please, we would love to hear some experience from. I'll tell you what, I have not used insulin, but I do love autologous serum. I think in my hands, it treats a lot of those stage 1s by itself. And my question to you is then, what is the additional benefit you're seeing from insulin on top of that? I'd be very curious to hear.
And I have some people that for whatever reason have not done as well on AST and have done okay on insulin. So I do think there's some we don't know, but most people, they just don't want to give their blood, and that's what ends up on insulin. So I still don't know if there's one is better than the other and in what situation.
Amazing talk. What I think is, I really like to think, I know they're completely different things, but I like to think the same way I like to think about the losartans. Like, if I don't have anything else to do with the patient, I try insulin. I have some few cases, some few experience. One of them was like an old man with 90 years old with a persistent epithelial defect, and they referred to me to do a amniotic membrane transplantation, but he has 90. And because of this reason, he also didn't want to have like the autologous serum, the blood. So I said, okay, let's give a try with the insulin. I am very like you. I started with 1 unit, and then after 1 week or 10 days, it closed the wound, and it was very good. At Sorocaba Hospital, we've been treating some patients most of them are doing well, tolerating the 1 unit ml, but a lot of other centers in Brazil, they're treating with 25 units, is very well tolerated. But sometimes you have one or other patient that has like some infection in this meantime. So I really think we also need like more research on this to really know. But I think it's amazing because thinking about the cost, because observates the neurotrophic factors, they are very expensive, especially for us in Brazil. So it's very hard to ask the patient to get like observate or something like that. So I prefer to try the insulin first.
I have a question. So I'm an oculoplastic surgeon, so I'm just coming at it from a totally different angle. But you said that you like to treat patients that have more mild NK. Does it matter the etiology? Because when I think about NK, I think about preganglionic and postganglionic etiology. And I think that preganglionic etiology, like a neurosurgical procedure in the brainstem or a congenital NK, I don't see them working with oxybate. I don't see oxybate helping those patients. Do you think that insulin would work based on the etiology, or is it just on the clinical presentation?
Right. So again, it's a great philosophical question. The data suggests, though, that it does work on some central cases, because if you look at the repro study for oxybate, some were centrally mediated NK. And the thought is, what are we really doing with these neurotrophic factors? If we're just helping the epithelium, and we're not really regrowing nerves, which is what we think, it actually doesn't matter the cause. And so I think that the way I think about it is we're helping epithelium just do a little better, and that's what most of these things are doing. If you look at the nerve regrowth studies, they're not that robust, so I don't think about it in terms of etiology. I would say I'm in the US where there's a medical legal issue. If I have grade 2 or grade 3, if like the eyeball is melting in front of me, I probably will go to oxybate, even though it's much more expensive, because I don't want to have someone perforate and then be asked, like, why didn't you use what an FDA-approved product is? But I think that there has been great data that even grade 2 NK responds to insulin. It's just that I think in the US, we generally use FDA-approved products first. So that's when I jump to that.
So I have a question on, I know you put the question on your slide, but...
You can ask any question you want.
The stability of these compounded products, both with losartan and with insulin, like, we don't know.
Right, like someone should actually study that. That would be a great idea.
But when you're dispensing them to patients, what do you tell them?
I tell them that the pharmacy says that they're only good for 2 weeks, but you can use them for longer. I feel that way, but I actually have no data to support that.
Do they have to refrigerate it?
I also tell them that I feel that they should refrigerate it, but I also have no data for that.
It's like Botox.
It's the same with losartan?
Yeah, it's the same. Some pharmacists are saying, no, you don't need to have it refrigerated. So since the patient has to take it 6 times a day, it's hard. What I say is, oh, do you work from home or at your place you work? Do you have a fridge? Leave it there. If not, okay, go outside with this, apply the drops. So when you come home, put again in the fridge, but it's no data. It's just like trying to make it easier because it's 6 months treatment. Otherwise, they'll say, I want to get this drop. So it's better to try this way than nothing. And I would like to ask you a question about the dry eye. Do you have experience with the insulin?
I feel so strongly about this. So I hate the word dry eye, like, unless you really mean it. Like, what does dry eye mean? I think there are so many subtypes of dry eye, and I think that maybe diabetic dry eye is just NK, right? So I think that dry eye that involves nerve dysfunction does well with insulin, and I haven't seen good data that like autoimmune Sjogren's dry eye that doesn't have NK does. So I think dry eye, we need to do better with our terminology and figure out what the underlying contributors are and then target them. So that's why I don't like the term dry eye, because it's just like back pain. How do you treat back pain? It depends. But it could be that it would work in immunological cases. I just haven't tried it.
Thank you so much. Great philosophical discussion. We're going to move on to a very fascinating topic, mitomycin intravascular chemoembolization. Dr. Grau Hernandez.
Thank you for the introduction. So MICE stands for mitomycin C intravascular chemoembolization for corneal neovascularization. And just as an introduction, corneal neovascularization is certainly a public health problem. Now, the reason for it to happen can be from infectious disease, chemical burns, whatever you want, contact lens use. And in the end, we lose the antigenic privilege of the cornea, we get opacities, and for example, as the case we just saw before, it hinders the prognosis of a talc or a procedure. So we need to treat these patients, and mice is one of the alternatives. So currently what we have now is steroids, probably the first-line treatment. We all use them. They don't really work in very heavy neovascularized corneas, and certainly they do not work when the neovessels have been established for a long period of time. Other agents like clospiron, which it does work a little bit, especially when the eye is inflamed and the neovascularization starts. And anti-VEGF, which are, at least in our setting, they're very expensive to use. They're not approved for corneal use, but you can certainly use them, and it's expensive. And they do work when supplied in a timely manner, when the neovascularization is just starting. On the other hand, we have the surgicals and procedures. Laser photocoagulation may enhance pro-angiogenic factors. You can use them when identify a single vessel. Fine needle diathermy, just in the time of surgery, or very sophisticated treatments like stem cell-based therapy. But certainly, there's a need for a treatment that can be applied once in the office, and mice could certainly help you with that. It's not that I have no commercial bias towards mice, but it can be in an office procedure. How do we do it? We try to identify a vessel that's coming in from the periphery. It has to be a thick vessel. Very fine vessels are very hard to canalize. And the way it works, so the theory behind it is that it kills the endothelial cells, the pericytes, within the vessel that's inside the stroma. And the safety, we use mitomycin field, not all the time, but we use them routinely in the clinic. And the learning is from our oncology colleagues that use it as intravascular to control the tumor growth in hepatocellular carcinoma. So right now, the indications for mice is very certainly visually significant neovascularization with keratopathy. Obviously, the eye has to be as quiet as possible, no infectious disease process, and currently we use it only for established neovascularization, not just the one we just see starting coming in from the limbus, but the one that has been there for months. And in fact, you have to identify a proper vessel that you can actually canalize or put the needle through. So you can use a very fine needle from 32 to 34 gauge. In our settings, not always we have a 34 gauge, we use a 32. But when you use it in the slit lamp or at the minor procedure room, you have to be very careful to rinse through once you've injected the mitomycin into the vessel. So what we do is we mark, we look at the feeder vessel. This is easy to do at the slit lamp when the vessels are inferiorly. When the vessels are coming up from the top, then might as well bring the patient down, lie it down in the minor procedures room, and do this under the microscope. And the first report came only a couple of years back from Mimumi et al. So he published a pilot study over 3 patients treated. The vessels regressed 100%, and the vision improved in these cases. These are the cases that he published then. You can see the vessels coming in from the periphery with lipid keratopathy. He canalized the vessel, injected the mitomycin C, and 3 months they were clear. We started using the mitomycin a couple of years back, and now we published our own series. Most of the cases are between a year up to almost 4 years of follow-up. So small samples here. There's 8 patients from different etiologies. Most of them were HSV, but we treat the patient with an ICR-related corneal neovascularization. Let me go back to the slide here. So what's important, the message is that if you can manage to inject the mitomycin into the vessel, most of them will regress. Not at all, but at least for improving prognosis for corneal graft. So in our own case here, we had a decreased vessel area of 66%, which is impressive. compared to the results we have with anti-VEGFs or cautery or biothermy or steroids itself. So our trial was the first published long-term results. So these are some of the patients that we treated. These are HSV-related corneal neovascularization. You can see the patient number A, where you can identify 3 feeder vessels. Those were injected in the slit lamp. Also, this one here is HSV-related. This with 1 feeder vessel on picture B, and 3 months after. These patients were followed up, the patient on top, for almost 4 years with no complications. That doesn't mean that it could not happen, but we need to be very wary of the secondary effects of mitomycin C, but certainly an option to manage these patients. This is just recently a patient with a very heavy neovascularized cornea, obviously very poor prognosis for a PK or for a DALK or whatever procedure you wanted to do. That's also HSV related. It's only 2.5 weeks after mice. You can see a very decreased corneal neovascularization. The opacity has decreased as well. Some of our own patients improved the visual acuity in the first cases that we published. This is another case. Just 1 month after mice of PKT, the vessel had been there only starting, but we injected mice, and you can see how the vessel disappeared on 1 month after mice. So this is a table that we published. 8 patients, very small sample still. They still need to be compared with other methods, but most of them improved significantly the neovascularization. So I guess the message is, have this in mind. It's something that you can use in the clinic or in the office, especially when it has the neovascularization has not regressed with standard treatment. So right now at our center, we're comparing mice to anti-VEGF therapy, also injected. Hopefully by the end of the year, we'll have some results. So there's certainly limitations. We need to be wary of side effects. We need to wash the ocular surface heavily after we inject the mitomycin C. There are only case series reported, so we need more evidence on how to use this therapy. Also the dosing, if we can repeat it safely. In the case we need to inject several vessels, how much can we use without putting into the predicament the prognosis of the patient. But the message is, consider mice in chronic corneal neovascularization with feeder vessels that can be identified. And I think with that I'm finished.
I absolutely love this idea because these are frustrating corneas, and you're absolutely right. Argon laser doesn't work well. They always come back. You know, subconjunctival, we did Avastin for a while. That tends to recur as well. So the concept is really great. The challenge I've seen with this is that we can't get a fine enough needle to really cannulize every time. And that's the challenge. I feel like if we can get something fine to be able to cannulize every time.
Technically, it's difficult.
Yeah.
I've just recently did one case. We've tried everything on him, everything. He was heavily neovascularized, and I injected him in the OR. And although I couldn't find the exact vessel, when I pushed it, and then you push the mitomycin, you can see blanching. And it worked a little bit on him.
So that's actually a really good question. If you're kind of close and not necessarily right in, do you think you can still have an effective treatment? Is there also concern for limbal melt?
There you go. That's when you're not injected right into the vessel. I always have in my heart, like, what's going to happen to this cornea afterwards? But we have tried everything on him, so I hope it, and it did help at least a couple months after he was better. And I think I'm going to be well. I think I could repeat the procedure if necessary.
Caution. I totally buy this for a vessel that is causing an opacity. I don't fully buy it as a way to decrease the risk for a corneal transplant. Because when I see vessels in a cornea, that means they're limbal vessel. There's lymphatics as well. And it means that that cornea is already loaded with inflammatory cells. So I don't know that in preparation for a high-risk corneal transplant, this procedure makes it any lower risk. But if you can avoid a corneal transplant, that to me is a success. So. but maybe it does.
I don't know, we out of our own 8 patients, 2 had corneal grafts. And so far, they're so good. It's only, a year after.
So Enrique, what is the size of the needle you usually?
34 gauge.
34.
It's a very fine needle, yeah. But no, we don't always have it available. You can use a 32, which is insulin syringe. And if the feeder vessel is wide enough, then you might be able to get through and inject the mitomycin.
And this is always in the operating room? Or?
No, we've done it as slit limb. As I said, when the vessel is inferiorly, it's easy to do it in the slit limb. When it's superior, you might as well have the patient lie down in a minor procedure room with just a few drops of probarcane.
Thank you so much. Fantastic. We're going to move on to Dr. Kossler to talk about minor salivary gland transplantation for keratinizing ocular surface disease. And do you have the clicker? Yes.
Thank you so much, and thank you for having me. As I mentioned earlier, I'm an oculoplastic surgeon, director of oculoplastics at Stanford, so I have a totally different take on these ocular surface diseases. Can I have my slides? Oh, we just go straight. Okay. So I have a totally different take on these ocular surface diseases and really appreciate the opportunity to work so closely with my cornea colleagues. Together, sometimes we can treat very complex cases. And so what I'm going to talk about is the minor salivary gland transplant, just to make sure it's at top of mind for everyone and something to consider in patients that have really end-stage ocular surface cicatrizing diseases. And so I'm going to present a case. So this is a 75-year-old male. He was diagnosed with Stevens-Johnson syndrome in 2004 from allopurinol use. And he went through many years of complications with his Stevens-Johnson syndrome until he finally came to see me in my oculoplastics clinic. And he came to see me because the recommendation was for me to perform an 80% tarsorrhaphy on his eye. He had failed 2 previous corneal transplants. He had recurrent fungal infections. He had recurrent ocular surface inflammation, dry keratinized and conjunctivalized ocular surface, limbal stem cell deficiency, neurotrophic cornea, but he was also light perception in the right eye. And you might wonder about the left eye. Unfortunately, that eye had succumbed to his Stevens-Johnson syndrome before I met him and progressed to an ankyloblepharon with no light perception in that eye. And so the first question that I kind of have for the panel that we can talk about, but I'll kind of answer to get started, is really when do we consider minor salivary gland transplants? Who is the proper patient? And so since I learned this procedure, I actually learned it from Dr. Basso over there, but since I learned this procedure, I've learned who you should not operate on, and I think also some people that really do benefit. So this patient actually really did benefit from a minor salivary gland transplant because he had a very keratinized ocular surface, and what the minor salivary glands can do is bring a high level of lipid and mucin to the ocular surface. It doesn't necessarily produce a lot of aqueous or increase the tears significantly, but it can really bring a lot of lipid and mucin, and that can often be a big thing for keratin, for burning, for pain, and it can make the ocular surface moist enough so that our cornea colleagues feel more comfortable when performing certain corneal procedures. And so and I would love to get everyone's opinion on minor salivary gland. I don't think I have enough time to show the video, but happy to share it with you, anyone that would like to see it. But this is a picture of the video and what he looked like on the day of his surgery. You can see how incredibly keratinized this LP eye was at the time of his surgery. And then I'll just show you what he looked like 2 days after surgery. So you can see this, this strawberry-looking purple thing there. That's the minor salivary gland transplant. And this is a month after surgery. He went from no Schirmer score at all to 3 millimeters, and 6 months after. And the thing that he noticed was that he didn't need to use artificial tears as often. His eye always felt quite moist, and every now and then he'd have a drop of tear go down his cheek, and that was always a big celebration for him. So what was most impressive is that this patient, who maybe has met some people in the room, because he went to every cornea specialist in the country, and he really consulted with everyone, and nobody was willing to do a K-Pro type 1 on him. He was told that he could only have an MOOKP procedure or a Boston K-Pro type 2, and everyone told him no way to a Boston K-Pro type 1. But after the minor salivary gland procedure, he had enough ocular surface wetting, the keratin had improved enough that Dr. Manis at UC Davis did a Boston K-Pro type 1. And after that procedure, he was 20/80 in the eye that was previously LP. And so this is what he looks like just a week after his procedure, and then 3 months later, and then 1 year later, and 3 years later, where his vision was 20/60. But what you can see in this picture is he does still have a little bit more keratin coming into the photo. He's a major VIP. We spent a lot of time taking care of this patient, preventing major complications. We actually celebrated his vision every year on the day of his surgery. But about 4 years later, on May 2024, he had a vitreous hemorrhage. His vision started to go. He underwent a pars plana vitrectomy. And then it was decided for multiple reasons for him to have a K-Pro exchange with an aphakic K-Pro, an IOL explant, another pars plana vitrectomy, and that just happened in March of this year. This is a very close patient of mine, and his vision is now quite unstable. About 2100, but he feels it's much worse than that. He actually still has a lot of keratin around on the ocular surface, a lot of dryness. He's constantly lubricating. We had to put him in this really tight tarsorrhaphy because anytime we opened it, then he would have complications. And so my question for the panel is, if and when do you consider a second minor salivary gland transplant? So he was just sent back to me again to do a second minor salivary gland transplant. So just want to talk about, when do we do that, and then, where do we put it? And then my other question, since I want to take advantage of the panel, I work with cornea specialists a lot, but I think that the success of the cases that I do really hinges upon the collaboration that we have. I've definitely done minor salivary gland transplants where there hasn't been good collaboration. I don't really think that they worked very well. So how do we co-manage these cases together? How can oculoplastic surgeons help you, and what can we learn to be better partners? And now I'm starting to look at his other eye, so I'm looking at you, Sion. What can we do for the other eye? That's the spare tire that I'm starting to think about. How am I going to rehabilitate that eye in case we lose the right one?
Open it up for questions. Those are a lot of great philosophical thoughts. I'll just put in my 2 cents here. With a lot of these severe ocular surface eyes, a big problem is the chronic inflammation, especially with Stephen Johnson. So certainly they're wet, they're very dry and keratinized, and supplying tissue that's going to provide mucin is going to be very helpful, but you have to concurrently also control inflammation. Otherwise, the risk of melt with any procedure is so high, especially with a primary keratoprosthesis. Any other thoughts from the audience, from the panel?
No, I think this case, Andrea, was immunosuppressed, I guess, as well, right? He was on systemic immunosuppression.
Yes, he had an inflammatory form of Stevens-Johnson syndrome, and he was on chronic immunosuppression, initially with CELL-SEP, but then he had complications, and then on methotrexate.
Yeah, so my primary indication for doing minor salivary gland transplant is this primarily, where you're planning a corneal procedure, but the surface is not conducive enough. I mean, in this case that you presented, I don't think that the keratoprosthesis would have lasted that long. If you had done it without a minor salivary gland transplant, it would probably have, the cornea would have melted, or the K-Pro would have extruded much earlier. And in this case, actually, it didn't really extrude. It's just that the patient had a different complication and underwent an exchange, which is debatable for a retinal complication. But it does work. It's a little tricky to choose from where you're taking the minor salivary glands and to also assess if they're working. But we have a very simple solution for that, which is just like doing a Seidels test. You can take a fluorescent strip and wet the lip to see where you can see the glands that are functioning, and also afterwards. And you can definitely do a second graft inferiorly, just like you did superiorly. It's possible. I've done in a few cases. But yeah, I mean, these cases are difficult, and when you're trying to find a solution, this is one way of doing it. The other way, of course, like you mentioned, is to do a type 2 or to do an OOKP, which are, again, they have their own problems.
A show of hands from the audience. How many people are doing a minor salivary gland transplant or work with their oculoplastic specialist to do them?
I have a question. How do you select how big the graft is? And it's just a matter of just looking at the glands, or how?
Well, as I mentioned, this patient sent me to India, and I learned how to do the technique from Sion and his team. And so what Sion says is that, so I think at the time you had said that you wanted 15 to 20 glands, but I changed the technique since, because it is so hard to get that many glands.
Can you hear me? Can you hear me?
Yes. Okay, we're gonna pause and jump over to our live surgery for a moment. Yes, we can hear you.
Yeah. Just few comments. I don't know if you have observed that I put it a smaller diameter because she had 14 dioptries of myopia. Well, we don't know if from the myopia only for the keratoconus, but in this case I like to do an undersize graft. The graft is 8.25, and this can give results in myopia dioptries of this patient. And single stitch are very important because as you can see now, the astigmatism is very low, and you can really control very well the astigmatism after 6 months, removing the stitch one by one and try to control the astigmatism. And the surgery was done in local anesthesia. The microscope is fantastic. I really love this new microscope from Alcon. And the patient was really fantastic. She cooperated a lot, even if she doesn't speak one word in Italian and one word in English, only Albanian language. Fortunately, I speak a little bit Albanian. Thank you so much for your attention. I hope you enjoyed the surgery, and I will see you soon. Ciao.
Beautiful case. Thank you so much.
If there is any question, I can answer.
All right, wonderful. Thank you so much, Dr. Sarnicola.
Okay. See you soon.
We'll see you soon. We'll see you
Okay.
soon. Wonderful. And we'll jump back now. Go ahead. I think you guys were in the middle of a discussion.
We were talking about how many glands to use. So, you know, it is true that Stevens-Johnson syndrome can affect the mucosa of the mouth as well. And so I use the technique that Cyan just mentioned, using a Florentine strip, and I just flip the lip out and push hard to see how many glands there are. And then I try to get as many as I can, usually about 15 if possible, but I've had to take grafts with a little bit less than that.
So again, for both the experts, if you do a minocellular graft transplantation that fails, would you do a second in another place or replace the one that failed?
You would want to replace the one that failed. Usually it doesn't because it's autologous, and if your technique is right, it shouldn't fail because there are no chances of immunological rejection. The only thing that can happen is if your technique is not right, then you can have fibrosis. So, you know, like the earlier techniques where you just take a lump of glands and you put them in subconjunctival space, that doesn't work very well because the glands are connected to the mucosa, so it has to be that en masse excision and transplantation that has to be done.
What he's talking about is having orbicularis oris on one side of the transplant and then the mucosa on the other, so that the minor salivary glands are sandwiched in between those two, so less chance of fibrosis and scarring around those minor salivary glands. I also haven't had a case reject or fail, but I do think success, your definition of success is relative. So I think that one of the problems that I face as an oculoplastic surgeon, sometimes patients are sent to me from other parts of the country, and the collaboration, the immunosuppression, so important. So I had a patient that I didn't think worked well. She's over the moon and happy, and so is the cornea specialist, but I don't think it worked very well because I don't think her inflammation was ever truly controlled. So if you don't control the inflammation, the graft isn't going to work well, right? So I think that collaboration has been super important.
Thank you so much. And we'll jump to Dr. Basu now to talk about mesenchymal stem cells for stromal scarring.
That's what I'm trying to do.
Maybe it's too far.
Am I too far?
She's checking.
Okay.
While we're waiting, what can we do for the other eye?
The other eye, this would be, I think, suitable for OKP or Boston type 2, but you could also do a bulbar reconstruction. Let me see if I can go back one slide. Yeah, you can also do like a bulbar reconstruction with a mucous membrane graft. And if you can, salvage the cornea, fit a scleral lens, do cataract surgery, I don't know if he's pseudophakic. If he's pseudophakic, then it's much easier. Yeah, if he's phakic, it's much tougher. Do cataract surgery on this eye. But it's possible. That would be the conservative way of dealing with this. Any other kind of reconstruction, it's doomed to fail in this. I mean, if you're trying to do any kind of limbal reconstruction, would you do a limbal reconstruction in this?
Well, if it's NLP, I worry that there's a glaucoma or
We
optic nerve
believe that
loss.
he has vision. It's so thick that the scar tissue over his eye is so thick that I feel that he has vision.
Yeah, I mean, there's ways of checking to see if there's still some you can use light and see if he sees anything. But if there's thought that there may be something, you could do a Cincinnati procedure. This would require tissue from a living related donor, as well as keratolimbal allografts, but to reconstruct 360 degrees, I often do collaborate with my oculoplastic surgeon to do a mucous membrane graft to reconstruct the lids as well. They actually, even if later on they need a Boston caper, I feel like they do better when you've reconstructed the limbus. You've gotten some of that inflammatory tissue away from the peripheral cornea. So I always start with that.
So is there a dryness or wetness threshold when you plan a Cincinnati?
A dryness? Well, you get, first of all, I haven't done salivary gland transplantation. I think that's a great idea. We do buccal mucosal graft or sometimes nasal mucosal graft, so you do get some mucosal replenishment of goblet cells that way, and also with the conjunctiva that you bring over from the living related donor, you get goblet cells that way. So there is some re-wetting of the eye just with that ocular surface transplantation as well.
All right, so I'll be talking about MSCs and corneal scarring. These are MSCs that are not naturally present in the eye. MSCs conventionally are derived from the bone marrow most commonly, but you can also get it from adipose tissue or from the dental pulp. But these are MSCs that are ocular MSCs and that are present actually in the limbus. So just like limbus has epithelial stem cells, it also has mesenchymal stem cells. And this is how you get these mesenchymal stem cells out of the limbus. So I'll show you a short video of how this is done. So the source of the tissue is from the eye bank, from corneoscleral rims that you throw away after your DALKs or your PKs. And you can take the limbus, digest it, and then incubate this, and cells start growing out. So initially you get mostly epithelial cells, but if you passage these cells, if you culture them again and again, then you can get a pure population of these cells, which are the MSCs, which are pure MSCs. And MSCs are essentially cells that are responsible for creating the extracellular matrix in our body. And so any issue with the extracellular matrix, MSCs are useful and have been tried for ECM remodeling and getting rid of problems that are there in the ECM. So scars are the most common problems that we have related to the extracellular matrix, because 90% of the cornea is extracellular matrix, it's the stroma. So we have been using MSCs for treatment of corneal scars and for other pathologies that involve the corneal stroma for essentially inducing scarless wound healing. So you basically can get rid of scars and also prevent scars from forming as the wound heals. So this is how we apply these cells. We just completed 2 clinical trials with preserved and unpreserved cells. I'll just show you the surgical technique very quickly. This is under topical anesthesia. The cells are actually suspended in one of the components of commercially available fibrin glue, and we use a sandwich technique where you put the cells with the glue first and the other part of the glue and let it gel. You could also potentially inject the cells into the stroma or give a subconjunctival injection of the cells. This is the technique that is approved by our regulatory agencies for our clinical trial, because all the animal experiments were done with this. But there are other groups across the world, including in the US, where they're doing MSCs from other sources, but using subconj injections and also intrastromal injections. So how do they work? Like I said, they are anti-inflammatory. So think of steroids without the side effects. So that's how MSCs work. So this is an example. I have a talk tomorrow if you're interested, where I will show you more cases. But I thought for this presentation, I'll just show you one illustrative case. This is actually a patient with Hansen's disease and neurotrophic keratitis. long-standing, treated with amniotic grafts, tarsography, non-healing. And this is 2 years post-op, but this is just with a single application of the MSCs using the technique that I showed before, just with prophylactic antibiotics for 1 week, no other eye drops, no steroids. This is a wet eye and it healed beautifully, and you know, as you can see, there's almost no haze in the eye post-operatively. So this is the MSCs that we have been working on. The other thing that you can do with MSCs, because they produce extracellular matrix, is that you can use the extracellular matrix to make other things. So one of the things that we are interested in is in 3D printing of corneal tissue. So you can use the extracellular matrix as the base tissue, and then using what are called light-based or extrusion bioprinters, make cornea or cornea-like lenticules using this extracellular matrix. So this is also very exciting. You can either get the extracellular matrix from the discarded tissue from the eye bank or the corneoscleral rims, or you can grow them from the MSCs that you get from the limbus. And these then can be used by the light-based printers to print corneal lenticules. And you know, you can think of many ways you can use these lenticules in refractive surgery. You can use them as stromal equivalents for talc, or you could even use these as inlays for refractive surgery. So this is what, you know, we have been working on, and this is the current corneal substitute that we have. It's called neocornea. And one of the things that with biosynthetic or biomimetic corneas or corneal substitutes, something that we have always struggled with is to get a combination of optical transparency and strength. And this is something that we have been able to achieve with this tissue. So you can see that it looks just like a cornea, but you can also handle it pretty well. And here, you know, my fellow is putting interrupted sutures here and trying to bury them into the stroma, and you can do that without cheese wiring. Most other alternatives that we have don't have this tectonic elastic strength, and so when you try to suture it, it breaks and cheese wires. And so the only way that you can put it is with a femtosecond laser or with glue. But we are trying to make this equivalent which you can suture as well. So it's not only transparent, but it has this elusive combination of transparency and strength. So that's where we are at right now. Thank you.
That was really an amazing one to end with. So this is fantastic. Shortage of worldwide corneal tissue. Do you see this as being a future option to use for worldwide corneal scarring?
Absolutely. I think that that's the direction in which we are going. You can optimize the tissue that we have in the eye banks, make new tissue with it, and also, you know, try to make these substitutes which can fill this gap between demand and supply that we have right now. Also for all other applications, you can make contact lenses. And it's a step also towards personalized medicine, because you can, for whatever you're making, these lenticules or contact lenses or corneas, customize it to the patient and not like have a general off-the-shelf therapy, because you can easily get an OCT or a topography, and you can take those numbers, put it in the printer and print exactly what the patient needs rather than one size fits all.
Is there an immunological reaction from the host?
So from the extracellular matrix, no, because it has no cells, and so it has no antigenic components at all. From the cells, potentially yes, but the good thing about MSCs in general is that they really don't incite an immunological reaction if you use it a few times. Multiple users, definitely they can, but it has to be from the same donor. So that's also an advantage, because you'll hardly ever get the cells from the same donor.
How about using the patient's own mesenchymal cells from liposuction?
You can. You could do that. The only problem with that approach is, you know, initially when we started out with this approach, it was more than 10 years ago. That was our original idea, that we'll take, you know, like most patients with scars will not have limbal stem cell deficiency. So you can probably take a limbal biopsy, grow the cells out. It's just that from a regulatory standpoint, it's very, very difficult, because the regulatory agencies want to ensure that you have some kind of standardization of the product. So it has to be the same product every time, and it has to meet those standards. With autologous therapy, it's really difficult to do that. So tissue transplant autologous is easy. Cell transplant autologous is, from a regulatory standpoint, very difficult.
Any other questions from the audience? Yes, please. Do you want to come up and use the... I know, I'm worried.
Thank you. All presentations are really interesting. And a question for Dr. Kosler. Do you think your technique could help the severe dry eyes disease too? Because I am wondering if we can use that for Sjogren's syndrome. But the problem is they have still dryness of mouth, so I don't think I don't know. I just asking.
I think that it can. I haven't done it on Sjogren's syndrome. Of course, you'd have to make sure that have minor salivary glands to transplant. But I have done it on severe dry eyes, and I've changed the technique in more recent years, thanks to one of my colleagues, Andrew Wrong, who taught me kind of a different way of doing this for ocular cicatricial pemphigoid patients. But I have done it for a very severe dry eye patient, and it was a much smaller graft. I placed it in the inferior fornix. And I think what it does is it does not improve the aqueous tears, it just improves the burning. And that's what I actually learned by a patient that was at this conference in India. And so I feel that that's very true. It really does help the burning and the light sensitivity. It really helps quality of life. So I think if you're selecting the right patient and giving them the right expectations, especially since we know that our dry eye patients, have tried everything and are willing to try anything, I think that it can help them with certain symptoms. But I do think you need to make sure you're not dealing with neuropathic pain or other things, right? Because it wouldn't help that.
And do you know if they have any problems with the mouth dryness or not?
No, I haven't had any issues with their mouth. It can be quite painful, if anything. So I definitely have had a couple patients have some, significant pain because you're in an area near the mental nerve there. So they can have some pain, usually only for a few weeks. But this is a technique that any oculoplastic surgeon can perform, and cornea specialists too. So if you have an oculoplastic surgeon that you're close to, you can have them read. Dr. Basu and Guillermo Mascor wrote a paper on this. There are videos. We have a video online. So any oculoplastic surgeon can learn how to do this. And I don't see a downside. I haven't seen any complications so far, knock on wood. And I think that it can help with burning and pain and wetting, and it can improve keratin. I wouldn't say it does more than that.
Thank you.
I have one question about mice. It was fantastic, your talk. I'm really excited about this. I just have experience with anti-VEGF. And hearing you saying like you do this in the slit lamp, I would like to ask some advices if I try to do, because my fear is if I do something wrong, and perforates and then goes to the anterior chamber or something like this. And also if you do together with corneal transplants, if you do the mice and then you wait some time, then you do the PK or you do all together.
The few cases that we've done it, we've waited more than 6 months to do the graft. And although it's really easy to do it in the slit lamp when it's inferiorly. On the few cases I've done, the 360 degrees or only superiorly, I'd rather have the patient lie down, get a forceps, hold the eye tightly and get the needle. But with just putting the blephariostat on, some proparacaine drops, and a tiny needle, you can, if it's inferiorly or nasally, either nasally or temporally, you can do it. It's not complicated, and it's a very, it really is not as hard as it seems.
Okay. Sometimes it's so hard to do anything like this little lamp. I was thinking about it, but the tricky thing is to get the thinner needle, the 34.
The 5 needle, the 34, 32 needle works as well if a feeder vessel is wide enough.
Thank you everyone for your attention, for being here this late, and hope to see everybody tonight.
Thank you.
Thank you so much.
Thank you.
Thank you, Pam.